Welcome to the Flight Bridge Ed podcast series. Hey folks, Eric back with you. Today we're going to continue with our Nightmare series, and we're going to do a case study that was sent to me from a flight paramedic out of Southern Oregon. I first want to say Happy Memorial Day to everybody. If any of you out there listening have had a loved one lose their life in the line of duty, whether you're military, police, fire, or any other service-oriented position, I just want to say, we're very thankful for their service, and we're very sorry. So today's that day to honor them, and then we just wanted to take that moment and say that we do appreciate your family's sacrifice. Like I said, we're going to do a case study today regarding the Nightmare series that we've done since I think this winter. We started this Nightmare series. We've had many emails over the past 4 or 5 months from different people around the country just stating that they like this format, so we're going to continue with that format. This case is pretty cool. We're going to kind of go into the case. I'll read you the case, and then we're going to jump into some pathophysiology related to head bleeds, the different type of head bleeds, the pathophysiology, and some things that we want to make sure we take care of as clinicians while we're transporting these patients. So I'll jump into this. Basically, this is a 55-year-old female patient, history of a ground level fall at her house about 3 weeks ago. She was diagnosed via CT with a small subdural bleed in the frontal lobe. Her doctor decided to put her on bed rest, send her home, and she was instructed just to rest. The way this case presents, she had some headaches over the next 3 weeks, so we're kind of 3 weeks out. She's having headaches, she's having neck pain, and so she starts to go to the chiropractor. While at a chiropractic visit, she all of a sudden goes agonal, unresponsive, and collapses. EMS arrives. She's at a rate of 4 breaths per minute, agonal respiration. She's intubated on scene via EMS and taken to the local hospital. At the local hospital, they do a CT scan. They identify that she now has an aneurysm, a subarachnoid hemorrhage with a 6 millimeter shift. At this point, the hospital decides to transfer the patient up to the Portland area to a level 1 trauma center, and the flight service is requested, and they arrive. On their arrival, they identify that the patient is being ventilated appropriately. She's 70 kilos. She's got an 8.0 ET tube. She's currently on a vent settings of 500 tidal volume. She's at a rate of 16. She's currently on assist control, FiO2 of 60%, 5 of PEEP. They immediately realize that she's overbreathing the vent, and they switch her to a SIMV mode of ventilation to help with her spontaneous respirations. And if you've heard me in all my podcasts, that is a standard now throughout the country. If you're listening and you're kind of scratching your head and you're saying, well, that's not what we're doing here, you should be doing that. That's what's happening in all the level 1 facilities, whether you're pediatrics or you're an adult subset of patients, and that's progressing throughout the ICUs throughout the United States, and that's becoming the standard. So they switch her to an SIMV mode of ventilation. Their blood gas, they request a blood gas while they're packaging the patient, which I think is outstanding. Anytime we can do that, remember that takes 5, maybe 10 minutes at the max, and if you do it early in your care, you're not going to really delay any transport times. Her ABG, she's got a pH of 7.38. She's got a CO2 of 38. She's got a bicarb of 20. So, pretty normal. Bicarb is a little bit low, but nothing that's going to be raising any red flags. They have her on a propofol drip at approximately 50 mics a minute, and she's got normal saline, renin, and TKO. At this point, we're going to jump into the pathophysiology, and then we're going to come back and finish off the case. So at this point, let's talk about the different aspects of head bleeds. For those of you that are preparing for your advanced certification exams, there's 3 or 4 main head bleeds that you need to really know. The first one being an epidural bleed, second one being a subdural bleed, third one being a subarachnoid hemorrhage, and then you need to understand what diffuse axonal injury is, and we'll hit on these very, very quickly. I'm not going to spend a ton of time on this podcast. Hopefully we'll be completed in 12 to 15 minutes. The first thing we have to remember when we look at any type of head trauma is we have to understand the pathophysiology related to a term called Monro-Kelly hypothesis. And Monro-Kelly hypothesis basically states that you have three types of components in your brain. You have blood, you have the brain itself, and you have cerebral spinal fluid. Each one of those makes up that portion of the cranial vault. And any increase in one of them, you need to decrease the other one. So if you have an increase in blood in that area, there's really no way to release that unless you have surgical intervention. So what this causes is increased ICP. So Monro-Kelly hypothesis basically states that if you have a fixed space, you have all three of those components, blood, brain, and CSF, they all maintain a perfect ICP. And any increase in one of them based on trauma, based on some event, there's got to be a decrease in another one or you're going to have an increased ICP. And we know that increased ICP is a bad thing. All right, so continuing. Let's talk about really quickly ICP. ICP is maintained at a normal range between 0 and 15. And when we're dealing with our patients, we're not going to have a bolt in place when we transport these patients. So it's really hard to identify what your patient's ICP is. So what I always do is I know my range for a normal healthy adult is 0 to 15. And if I'm calculating that, we have to know the formula. And the formula to calculate that is basically MAP, your mean arterial pressure, minus your ICP. Well, we just said ICP is something we don't know. So we kind of have to guess. And so I use the high range, the 15 is my number. Then we have to identify our MAP. We know our monitors out there, they will actually spit out the MAP, and you've heard my other podcasts, and MAP is the thing that we want to always be monitoring. I could care less about a blood pressure, really. I want to know what my MAP is. I want to know that I've got good perfusion. If I've got a MAP of 60 to 65 on a normal patient without a head trauma, I'm going to be happy. When we have a patient with head trauma, though, we need to maintain a MAP a little bit higher, and here's why. Because we want a cerebral perfusion pressure of approximately 70, and we know a cerebral perfusion pressure of 70 perfuses the brain well, and that's where we kind of want to meet. Well, if it's MAP minus our ICP, and we normally want to keep our MAP around 65, and I said we have to minus some arbitrary number, and I used 15. Remember, 0 to 15 is your normal range. 65 minus 15 is 50. Well, that's well below what a normal cerebral perfusion pressure is. That would be a cerebral perfusion pressure of 50, and that's not going to cut it. So to maintain a cerebral perfusion pressure of 70 on a patient with a higher than normal ICP, directly related to some type of blunt force trauma, some bleed, something that's going on that's causing that Monro-Kelly hypothesis pathophysiology to be off, right? So that's what's causing the ICP. We have to maintain a MAP of around 85 to 90 now to maintain good cerebral perfusion pressure. So it's very, very important to realize that our MAP needs to be significantly higher in our patients that have any type of head trauma or head bleed with increased ICP. The other thing to remember, metabolic demands, when we talk about our brain, 20 to 25% of our cardiac output goes directly to perfusing our brain. So that, again, kind of plays into maintaining a higher MAP. Let's talk about the role of CO2 and CO2 as far as regulation. When we discuss, we've all been taught that over the years we wanted to hyperventilate our patients. You know, that was kind of the early science when I first started in medicine. We wanted to hyperventilate our patients. And then when we started using capnography, we always said, you know, let's maintain a capnography number of around 30. And if you start reading the literature and anything that we do in medicine, as we progress, we're starting to see that less is better. And so what I mean by that, we've already identified in other podcasts that less fluid in sepsis, less fluid in trauma is better. Less fluid in burns are better. Well, this is the same thing. We don't need to hyperventilate our patients. We just need to keep them on the lower end. And so most literature is now saying if you can maintain a end-tidal CO2 of about 35, you're going to be good. You don't want to go too low, because too low causes too much vasodilation. If you have too much vasodilation, you're going to have more perfusion. You're going to have more blood that's going to flow into that brain. Well, that's going to completely mess up based on that Monro-Kelly hypothesis. Remember, cerebral spinal fluid, brain, and blood. Well, if you have too much blood that's flowing in, you're actually going to cause more ICP directly related to that vasodilation. We know that if we keep that end-tidal CO2 too high, so hypocapnia, that's going to cause vasoconstriction. Well, that's not going to perfuse the brain at all, and that's going to cause basically a bigger issue up to including, hypoxia and death. So we want to keep it in that perfect range. 35 is that perfect range. We don't want to go into the 30s. We don't want to go into or low 30s. We don't want to go into the high 20s. So 35 is kind of where we want to hit. The other thing we want to think about when we look at patients with any type of trauma to the head, the two big things that we never want to have is any hypoxic events or any hypotension. Okay, those are the two big things. Mortality and morbidity skyrocket above 50% when we have something like that happen. So no hypoxic events. So that means if you're intubating a patient that's got some type of head bleed, we don't want any ever in a hypoxic event, and we never want hypotension. That's a bad thing. So let's talk about the different head bleeds. We said in her presentation she was diagnosed with a subdural bleed. All right, and we'll start with that. She was diagnosed with a subdural hematoma on the frontal lobe, and we know that subdural hematomas, they have a very high mortality rate. 40 to 50%. And the reason why is because they can be very subtle. They can be missed very, very easily on a CT if they're very small. And patients can manifest their symptoms over weeks. Obviously, some subdural bleeds, if they're significant enough based on the trauma or the mechanism, they can happen immediately, but they often can develop over a long period of time. Because it's below the dura mater, it causes more problems. It causes those shifts. It causes those ventricles to shift over, and that can be very, very ominous. Now, I have to question this physician. Obviously, I don't know who this physician is, but any subdural hematoma like that, just sending them home for bed rest, I kind of question that. Obviously, she was continually having symptoms, severe headaches, neck pain 3 weeks after the event, and so I kind of question that. Feel like she probably should have been admitted and monitored a little bit more closely. So let's talk about a few things when we look at subdural hematomas in the care. We always want to deal with the airway. If the patient can maintain their own airway and they're capable based on their mentation, their GCS, then let them maintain their own airway. But we always want to be thinking advanced airway management with any type of severe neurological insult. So with that, good airway management, first pass success, the biggest ET tube that we can pass, maintaining an end-tidal CO2, like I said, in that 35 range. Confirm adequate hemoglobin. Remember, in any oxygenation state, our hemoglobin is the biggest factor that represents how we're going to transport oxygen. So if you look at a critical care formula based on oxygen delivery and oxygen uptake, cellular uptake, the biggest factor in that equation, and if you have my books, go to the first chapter, and there's those formulas in there. Those formulas, the biggest factor that affect that formula is your hemoglobin. So we have to make sure we have oxygen carrying capacity. So is this subdural bleed a patient that's got a multi-systems trauma? Do they have other problems going on? And do we have adequate cardiac output? We said that cardiac output, 25% of our cardiac output goes to perfuse our brain. So we got to make sure we have good cardiac output. The other thing that we can do on these patients is we can give them some type of diuretic, whether it's mannitol. Sometimes they'll give Lasix, but mannitol is the primary medication. The reason why we like to give mannitol, or it's given, is it's an osmotic diuretic. It decreases the viscosity of the blood. It improves the microcirculation, so we get better perfusion. We get better circulation throughout the brain in a brain that's already hurt. The other thing that's very interesting is we've talked in the past in podcasts about sodium. And sodium is a big thing when we talk about acid-base balance. We've talked about sodium and chloride and now albumin being big factors in how that acid-based arrangement kind of plays out. We know that an acid, sodium is an acid, and so we want to maintain a higher than normal sodium level in patients that have a subdural bleed. And the reason being is that sodium also is a big player in how things shift in and out of the cell. A higher sodium level is going to cause a shift of fluid out of the cell. So your cells are going to become less hydrated per se. So we want to pull. Think about the hypertonic and hypotonic kind of mechanisms. A higher sodium level is going to pull fluid out of the cell. That's going to decrease swelling and edema. So maintaining a serum sodium of about 155 is kind of the goal in our patients that have a subdural hematoma. The way they do that oftentimes is they'll give us 3% normal saline, and 3% normal saline is something you want to be very careful when you give, and it's often given to patients that have a hyponatremia. And we know that a hyponatremia, sodium that's very low, causes edema in the brain. We see that a lot in our pediatric population. Pediatric population that maybe they've been given a lot of water instead of other fluids, and they've got a dilutional hyponatremia, so they'll give them 3% normal saline. They'll raise that sodium up very slowly. In this setting, their sodium was already normal. They're just raising it higher than normal to 155 to kind of reduce that edema. And then the other thing we want to watch is we want to maintain a serum osmolality of less than 320. So our normal serum osmolality range is 270 to 290, 295 range. And basically what that is that measures the solutes inside the cell. So again, if you have a high number, if 295 is the high range, that means that you're becoming more cellularly dehydrated, and that's kind of how I think about it. Serum osmolality is a really important thing to look at. So if we want to keep it on the high range, we don't want to get it higher than 320. We said that 295 is the high end, so 320 is significantly higher, but we don't want it higher than 320. And then if these patients are intubated on the ventilator, putting them in a barbiturate type coma to rest them, to reduce their metabolic demand, is also something that can be done. All right, so we said that a subdural hematoma is something that has a very high mortality rate. So these patients need to be taken seriously. They need to be treated in that way. These patients need to be treated aggressively, and oftentimes when we're transporting these patients, we are taking them to a neurologist from a smaller facility to a larger facility to take care of that subdural bleed. Okay, the next bleed that we want to talk about is an epidural bleed. An epidural bleed is something that they love to ask on these certification exams, advanced certification exams, whether it be the FPC, the CCP, -C, the CFRN, the CTRN. This is a classic advanced certification style thing. So it's very important to know all about epidural bleeds. The big thing about epidural bleeds are very survivable. There's a very low mortality rate with these. And think about a bleeding that's between the dura mater and the cranial vault. So the blood is pooling between the bone and that thick membrane, and so it starts pushing on the brain. And so when you see this on a on a CT scan, it's going to look very perfect. It almost looks like an eyeball with a cornea. And that's how you identify it on a CT scan. It's going to look very perfect because the dura mater being so thick, the blood is not going to take the contour of the brain. It's not going to take the contour of the subarachnoid membrane like you would see with a subdural hematoma. Subdural hematoma looks very wavy. It kind of takes the shape of that subarachnoid membrane, whereas an epidural bleed does not do that. Okay, so the big classic thing that we see with epidural hematomas is they have a period of unconsciousness right after the event. Then they become responsive, so they have a period of lucidness, and then they start deteriorating, and they start going down into another period of unconsciousness. If you find your patient that has had a period of unresponsiveness, they've become lucid again, GCS of 12 to 14, and you start seeing them starting to deteriorate again, that's a very ominous thing as far as their airway goes. So anytime that you're going to transport a patient that has had a period of unconsciousness and it's been identified as an epidural bleed, you need to take immediate action with the airway. Always take immediate action with the airway and intubate this patient, because once they've had that period of lucidness, they're going to start going downhill again, and we're going to see that airway deteriorate. They become clenched, trismus, and you're going to have a very difficult time. Again, these are very survivable. They just need to drill into their cranial vault. They need to drain that blood out, reduce that ICP, and these patients do very, very well. All right, the last type of bleed that we're going to talk about is a subarachnoid hemorrhage. And essentially, a subarachnoid hemorrhage is probably the most common type of head bleed that we see. It can be secondary to blunt force trauma. It can be secondary to a gunshot wound. It can be or an aneurysm. And so with this patient that we're talking about here, this was secondary to an aneurysm. So she had that subdural bleed, and then she progresses. 3 weeks go by, and she collapses in the chiropractor's office, and she's diagnosed with a subarachnoid hemorrhage. These can bleed very significantly. She had a 6 millimeter shift, which is pretty ominous, and this patient didn't do very well. So when we see subarachnoid hemorrhages, a lot of times these are the aneurysms, right? These are the patients that have headaches. They may have a sudden onset stabbing headache, projectile vomiting. I've seen patients that have projectile vomiting. I've gone on scene, they've got this severe headache, they start vomiting, and then all of a sudden they go unresponsive or into seizures. So very, very ominous. Oftentimes these patients, usually die from these. Now I know that there are neurologists, interventional neurologists now, that if they can catch these bleeds early, if it hasn't shifted, if it hasn't caused other damage, they can actually coil these aneurysms and fix them, and they clot off very well. For this patient, this didn't happen, right? 6 millimeter shift, so it obviously bled very, very quickly. So those are the three big head bleeds that we're going to talk about today. So back to her case. So they identify, like I said, really quickly that she needs to be put on SIMV. They switch her to SIMV. They raised her rate up to 18. They have her on a tidal volume of 500, PEEP of 5, FiO2 of 60%. Remember, we're just going to keep an FiO2 as low as possible and maintain a SAT of 92 to 93%. She was on a propofol drip. Her blood pressure, they identified her blood pressure was lower than it should be, right? So where do we want to keep it? We want to keep it probably where she normally was. We never want, remember, any hypotension. That's a bad thing. So they identified a blood pressure of, let me look. All right. They identified a blood pressure of 100/68 when they started transferring over to their gurney. She was bucking the tube, so they started her on a fentanyl drip. They bolused her with some fentanyl at 100 mics, I think, and they started her on a fentanyl drip at 100 mics per hour, which I don't have any problems with. Fentanyl drip at 100 mics an hour, really, if you think about it, we give fentanyl at 100, 150 or 1 mic per kilo every 10 minutes. And so 100 mic per hour dose is very, very low. What they identify also is that she's on a propofol drip. We set at 45 mics a kilogram a minute. I know a lot of people out there listening, either you like propofol or you don't. And I think propofol is a great medication when you're dealing with a patient that has a blood pressure that needs to come down. And it's a medication that you can use to transport your patient, keep them sedated enough to get them to that receiving facility to where you turn it off, and then the neurologist can assess the patient neurologically very, very quickly. So it's great to use in that form. Okay, so when we look at this blood pressure of 100/68, we need to identify, does this patient have a MAP that's going to support a cerebral perfusion pressure of 70? Well, this gives you a MAP of 78. Any neurological patient, we said we want MAP minus ICP. We don't know what our ICP is. Obviously, it's massive. It's got to be huge. So we start with 15 because that's our high end of normal, and that gives us a cerebral perfusion pressure. If we were to calculate this patient, it would be in the low 60s. That's not going to cut it. So her MAP needs to be higher. This blood pressure is too low to perfuse her brain. So they identify this. They did an excellent job. They start decreasing the propofol. They decide the propofol is dropping her pressure, so they start decreasing it lower and lower and lower until they get it down to 5 mics a kilogram a minute. The blood pressure continues to drop. Blood pressure gets down to 88 systolic. MAPs were in the 60s, and they continue to completely DC and get rid of the propofol. They gave a 500 ml bolus at this time to try to get that pressure up, and they identify right then and there that they need some type of pressor. Now, phenylephrine is probably the best pressor that's going to give this patient the best chance, right? We know phenylephrine is going to have very little heart rate effect. It's going to have a good alpha effect. It's going to get that pressure up very, very quickly. They didn't have phenylephrine or neosynephrine, so they started her on a dopamine drip. They started her at 2 mics, and they started going up in increments until they got to 5 mics of dopamine. They got MAP pressures up into the 75 and 80s, but they couldn't get it any higher than that. They noted that there was no increase in heart rate with that dose. Continued to give her that fentanyl at 100 mics an hour throughout. She did very well as far as her sedation goes. So when we look at this, we have a few problems. The first thing we have to remember when we look at any type of head bleed is we don't want any hypoxia, right? And they took care of that. There was no hypoxia, but we don't want any hypotension. They didn't cause the hypotension. The flight crew did a very, very good job realizing that the patient was on a huge propofol dose that was causing a significant drop in her pressure. It wasn't meeting the needs cerebral perfusion pressure-wise, so they started dropping that off. They gave a very modest dose of fentanyl, which I don't have any problems with. Give the lowest amount to maintain sedation. They switched her to SIMV so she can overbreathe that vent. That allows her to keep that lower end-tidal CO2. Remember, we want that in the 35 range, so they did a very good job there. They didn't have neosynephrine, so they started with dopamine. They raised that up to that 10 mic range to try to get that pressure, that cerebral perfusion pressure, up as high as they could. Now, they only got MAPs in the 75 and 80s, which really isn't going to cut it based on her, and I don't think it really would have made a difference. I'm assuming that she probably passed away. So the other big thing we want to realize is the phenomenon of Cushing's triad. Cushing's triad, remember, is widening pulse pressure, bradycardia, and Cheyne-Stokes respirations. Now, she was way beyond that, right? She had normal pulse pressure. She had a heart rate that was normal, and she was already intubated, so she really didn't fall into that category. Remember, Cushing's triad is hypertension, it's bradycardia, and Cheyne-Stokes. A lot of people think they'll read the question and they'll say hypertension, tachycardia, and Cheyne-Stokes, and that is not Cushing's triad. That is increased ICP. So remember the difference. Increased ICP, you may have a hypertensive patient. You're going to have tachycardia, which is that initial response from the medulla, from the cardiac centers in the brain, and then Cheyne-Stokes. But as that pressure starts to impede on that medulla, on that pons area, then it starts to affect the cardiac centers, and that's where you start seeing the bradycardia, and that's true Cushing's triad. All right. Well, I think that we've gone through our three main head bleeds. We've talked about this case. I think they did a very good job. Remember, we don't want any hypoxic events. We don't want any hypotension. They identified very quickly that the hypotension was causing a big problem, that they didn't have an adequate MAP pressure for this patient. They did everything they could to try to raise that up, and I think they did a great job. The other thing to think about, if you had the medication, ketamine as a medication for this patient, that would have been very, very good. Kept her sedation down, analgesia, and it's very stable on a low blood pressure. So they didn't have ketamine at their disposal either. That's all I have for this case. If you have any questions or any comments or any other cases, please email the case to me. I love hearing different cases and hearing that you're applying some of the concepts that we've been teaching. We want to thank everybody for all the support. If you haven't purchased our books, we're doing a spring blitz at this time where everything's 25% off. I know most companies, Air Evac and Air Methods both, are requiring FPC and CFRN right now. Within 2 years or higher, and I know there's a big push right now FPC-wise for both companies at the end of the summer. So take advantage. I really feel like we have the industry-leading product with both of our books and our practice exams, and I'm really confident that you'll be successful using our products. And I'm always available by phone. We do have an Adobe Connect classroom. If you have a concept that you're struggling on, I have no problem setting an appointment with you and doing some one-on-one stuff. So please take advantage of those things. That's why we're here. That's why we founded Flightbridge Ed. And we just want to thank you again, and we'll talk to you soon. We want to thank you for following Flightbridge Ed.